Hello, I'm Sean Lyden. I'm the chairman of Department of Vascular Surgery at the Cleveland Clinic, and I'm a proud member of the VIVA Board of Directors. I want to welcome everybody tonight to Drug Elution data from Europe, a review of data shown both at LINC and Charing Cross, and this has been supported by Boston Scientific. I'd like to introduce our panelists and our speakers. From Interventional Cardiology, we have Dr. Eric Secemsky. Eric is from Beth Israel Deaconess Medical Center and Harvard Medical School. Christopher Metzger, who's at Ballard Health and Heart Institute. Interventional radiology, we have Dr. Andrew Holden, who's joining us from way down under at Auckland Hospital, New Zealand. Dr. Parag Patel from the Medical College of Wisconsin. From vascular medicine, we have Marc Bonaca from the University of Colorado, and from vascular surgery, besides myself, Dr. Leigh from UCSF Fresno. Dr. Eric Secemsky will be monitoring questions and answers throughout the session, and we encourage people to participate by sending us your questions. We're first going to begin with a presentation by Dr. Holden, who's going to talk about the performance of stenting in femoropopliteal disease, a systematic review and meta-analysis.
Hi, Andrew Holden here, and it's a pleasure to provide some information on a study we've done in conjunction with Boston Scientific, reviewing the performance of stenting in femoropopliteal disease. I say we have been pleasure to work with Professor Sabina Steiner from Austria and Jan Gouffet from France on this project, looking at a systematic literature review and meta-analysis of proportions. These are my relevant disclosures. So just by way of background, we know that from several important drug-coated balloon trials that as lesion lengths increase, we see the increased incidence of the need for provisional stenting to deal with the acute procedural complications like flow-limiting dissection and recoil, so that around 10% of cases with a lesion length less than 10 centimeters require a stent. But when we get to real world lengths of over 20 centimeters, we see around half of the lesions will need a stent. So certainly scaffolds or stents are something we need in real world management of femoropopliteal disease. We've also seen a significant improvement in patency over the years. With bare nitinol stents, we were used to seeing 1-year patencies in the order of between 65 and 75%. Now with drug-eluting technologies, we're consistently seeing patencies of 90% or over. And in fact, this is really illustrated nicely in this review of Eluvia studies. Some of these studies are pivotal trials with core lab adjudication, and some of them are single or multi-center registries, such as our own study in Auckland. But through this and through lesion lengths and lesion complexities, you can see that Eluvia has managed to achieve a patency at 1 year of 90% consistently. Contrast that to nitinol stents, including Supera and other nitinol stents, and we see a reduction in patency as lesions become longer and the lesions become more complex. So what we looked to do in this study was to systematically evaluate and analyze the outcomes of 4 common stent types used in femoropopliteal disease. That is the polymer-based paclitaxel eluting stent, Eluvia, the polymer-free paclitaxel-coated stent, the Zilver PTX, the Viabahn covered stent, and a range of self-expanding nitinol stents. And we looked at studies that had at least 50 patients enrolled between 2009 and 2024. The primary outcomes were primary patency, target lesion revascularization, and all-cause mortality at 2 time points, 1 and 2 years. This really utilized a pooled proportions analysis using a random intercept logistic regression model. There was also an estimation of heterogeneity in the study. And we also performed a sensitivity analysis dividing lesions into short, that is less than 15 centimeters, or long, that is 15 or longer centimeters in length. And the screening and analysis was independently done by the Corriva scientific group in Germany. Now, if we have a look at the study Prisma diagram, you can see there was a large number of studies initially identified, but finally 142 articles, over 50,000 patients studied. Just over a quarter of the patients had independent core lab adjudication, and 2/3 of the patients were rated in terms of quality of being fair or better. So let's have a look at some of the primary outcomes. You can see that the Eluvia in blue, then followed by the Zilver PTX, the Viaban, and nitinol self-expanding stents. Large patient numbers, but at 12 months, we can see the primary patency of Eluvia was significantly better than the other devices, who all had a similar primary patency, and there was no overlapping of confidence intervals. If we then have a look at 2 years, we can see the same phenomenon. That is an outstanding primary patency for Eluvia, but no overlap of confidence intervals between Eluvia and the other devices at both 12 and 24 months. If we then divide the groups at 12 months into short and long lesions, remember 15 centimeters was the cutoff there, and we can see that obviously there weren't covered stents used in the shorter lesions, but again, we can see that for both short and long lesions, very interestingly, the primary patency for Eluvia was not only better than its competitors with no crossing of confidence intervals, but it was sustained for both short and long lesions. And you'll note that is not the case for other drug-eluting stents or nitinol stents. So a really interesting, even more pronounced benefit for Eluvia as the lesions became longer and more complex. What about looking at the same analysis, but now out to 2 years? And really, we could see the same very interesting finding that even at 2 years, the primary patency for Eluvia for long lesions was essentially no different to short lesions, and it was just under 80%, so an outstanding result. But we can see a drop-off in primary patency for the other treatment, the other stent types, as we got out to 2 years. And again, there was a more pronounced benefit, therefore, for Eluvia for both the more complex disease and the longer that we followed these lesions. What about target lesion revascularization? Well, we saw the same trend favoring Eluvia. Eluvia had the lowest TLR compared to the other devices with no crossing of confidence intervals. We saw this phenomenon at both 12 months and 24 months. And so we can see that Eluvia had significantly lower TLR rates at both 12 and 24 months compared to the other stents with no overlapping of confidence intervals. Mortality, I mentioned, was also assessed. We would expect for a claudicant cohort such as this to have lower overall mortality, particularly at 1 year, and that is, in fact, what we saw. And we saw no significant difference in mortality at either 1 or 2 years for any of the stent types that were used. So really, we now have level 1 evidence on the comparative performance of 4 stent types that are commonly used to treat femoropopliteal disease. And really quite a surprising finding that Eluvia had the greatest patency rate across the stent types at both 12 and 24 months. But I think even more impressive was the lack of decline in performance of Eluvia at the longer time point, almost identical to the 12-month patency, and also a lack of decline in patency with longer lesion length, which is very interesting and was not seen with the other stent types. We saw similar trends for TLR at both 12 and 24 months favoring Eluvia, and as expected, mortality was no different between the stent types. Now, we should acknowledge some limitations of the study. This is a pooled analysis rather than a patient-level data review. And interestingly, there were some inconsistent definitions of primary patency. That's really centered around what peak systolic velocity ratio was used to define binary restenosis, and also how TLR was defined and whether it was clinically driven or not. But the conclusion certainly is that this results of this important study really show a consistent differentiated patency and TLR outcome for Eluvia at both 1 and 2 years compared to other stent options. And I think this long lesion data in particular can help us guide our decision when we need a stent, which stent we should choose. And so therefore, as we manage more and more complex disease, we can now make case-by-case treatment decisions based on the information we now have with performance with long lesion characteristics and long-term outcomes. Thanks very much for your attention.
So thank you, Andrew. That was an amazing presentation. Now I'm going to turn it over to our panel to sort of discuss this finding. And Andrew, I'll start with, I've always been someone who tried to be a not metal first person. That's because the early days of endovascular therapy, the first generation nitinol stents did fail. When they failed, it was really, really hard. So do you still use vessel prep and evaluate what your lesion looks like and then follow it up with DCB if you have a good angioplasty result? Or now putting this data in context with Eluvia performing so well, does it make more sense to do that? Or is there an advantage to do vessel prep and sort of see whether you need scaffolding or not? I mean, how do you work this into your own clinical practice, with all those armamentarium tools you have available to you in New Zealand?
Yeah, thanks, Sean. That's a great question. And I think the short answer is that I do still optimize vessel prep, and I think this is very important. And we have new and differentiated tools to optimize vessel prep. And like you, I've traditionally thought if I can get away with a drug-coated balloon and maybe a provisional stent, then I'll do that rather than the primary drug-eluting stent. If I get an excellent result with vessel prep, I'm still going to use drug-coated balloon, no doubt about that. But I think this kind of just helps me shift the balance. There's no doubt that this data has shifted the balance a little bit. So in those cases where I was indeterminate, uncertain about, is that grade C dissection? Is that recoil more than 50%? What's the flow like? I'm probably going to use the drug-eluting stent option more than I would have previously data for, mid to long lesion. So I think it hasn't really changed the paradigm. It's changed the threshold for me for going along the line of a drug-eluting stent early as opposed to a DCB and a provisional stent. And I think, I guess that's the best way I could answer that.
I got a question for you, Marc. Oh, you want to go, Chris? Ask Marc a quick question. Okay, go for it.
Okay.
Marc, I've gone back and forth with you on the Voyager data and just how we used, low-dose rivaroxaban with either aspirin and or Plavix or both. Any insights? I mean, if we're moving towards stenting long lesions, any insights on should we do triple therapy for at least a month? Some of us have done DAPT and then switch to low-dose Xarelto 1 or 3 months after stenting. Any insights from your data or clinical practice or observations there?
Yeah, thanks, Eric. I'm glad you asked the question. As I was looking at the 12% mortality, no difference between the devices, obviously, but it's pretty high. And I was wondering what kind of medical therapy, folks were on, because that's a pretty high mortality rate. And, I think it speaks to the need for better sort of pharmacoinvasive combined or holistic approaches. Here from a Voyager perspective, we had a large drug, coated product or drug-eluting product analysis or subgroup Connie Hess led, and we did that along with the FDA, sort of looking not only at mortality but patency reads, and we saw better patency for drug-eluting technologies, no difference in mortality. And then, in terms of the data for low-dose Riva, is clearly effective for that primary endpoint on top of DAPT. And there didn't seem to be any benefit to continuing DAPT for more than 30 days. It looked like you could drop the P2Y12 inhibitor at 30 days and then continue on with Riva and aspirin. If you do triple therapy for more than 30 days, there's certainly a higher bleeding risk. And we saw some interaction there. So the data would say, aspirin and Riva. And as I look at mortality and other outcomes, there's obviously additional benefits as you look at trials like Compass.
Dr. Metzger, you had a question.
Yeah, quick question. Back to your point, Sean, of not using a lot of, or leaving a lot of metal behind. We have a lot of data here on long lesions treated with stents. And I guess the question is, 2 years is probably not enough to know, but do we have any information on stent fractures? We don't seem to hear as much these days about stent fractures, but the drug-eluting stents are nitinol stents. And if we're treating long lesions, what's the feeling about stent fractures? Is it still an issue, not an issue? And do we have any information from this trial, Andrew?
Maybe I'd answer that first, Chris. I think we've definitely seen reported out stent fracture rates. Remember, quite a heterogeneous group of patients here, but the overall stent fracture rate with Luvia and in fact with the modern nitinol stents is significantly lower than what we see in the early days of nitinol stents. So we aren't seeing high stent fracture rates. Add that these trials typically exclude patients needing stents in P3, so they really contain femoropopliteal in the SFA and P1 segments where we know we're getting considerably distortion, elongation, those kind of stents. So I don't think stent fracture is gone. It's something I'll ignore, but there's no doubt that the dry stenosis, I think, are the neonatal hyperplastic drivers than stent fractures that we saw in the early days.
So Parag, what are your thoughts about this data set and how do you incorporate this in your practice?
Yeah, thanks, Sean. I had a couple of thoughts here as well. And thanks, Andrew, for this presentation. I think it certainly adds to the data that we have in support for lower reinterventions rate with drug-eluted technologies, and particularly in the polymer device. I think for me, the long segment data versus your short data is compelling, and certainly there's a lower reintervention rate through your 2 years of follow-up. To me, what's interesting, and I suspect many listeners who are following in the space wonder about the mixed disease and data presentations that are coming out recently, and are we seeing the 2-year lower reintervention rate, but are we going to continue to see that followed up out to 4 or 5 years? And given that there's new data that's coming out that may conflict some of this or counter this, I wonder if Andrew has any thoughts, and I guess I'm hinting at it a little bit, but I do think it's worth noting the recent trial data that came out of Sweden, also showing a lower reintervention rate in the early period, but followed out longer with a different cohort of patients, albeit there was an intermittent claudication group. So, Andrew, I don't know if you have any comments on that.
Yeah, I mean, I think it is difficult in the long lesion cohort. These generally aren't nearly as well controlled with core lab adjudication and time point sort of imaging compliance. But what we have seen in the short to medium length lesions is a flattening of latency of TLR after 2 years. So if we look at the longer term data, both Zilver PTX and Eluvia, we can see that actually the ongoing restenosis and TLR are quite small after that time point. They're not the rate of growth of them slows down significantly, and that actually reflects our own clinical practice. We actually had the longest follow-up of Eluvia in the world because we did the very first cases of Eluvia in the world, and I've had an opportunity with patients now, at 7 or 8 years, and the incidence of TLR after that 2-year rate, in our own experience, has been surprisingly low. So yes, we do see a group that develop stenosis, but often they're developing stenotic disease in the vascular segment outside of the device. Now, they're not pretty, but I think overall, I expect to see some sort of plateauing of TLR rates after 2 years. But the point about optimum medical therapy is key, I think, for this. And compliance. We have a very compliant cohort of patients who regularly turn up for surveillance and take their medication.
So we'll take one last question from Eric that he's got from the panel, and then we're going to go to his presentation.
Great, thank you. Yeah, Sean, so I'm going to bring in two questions and combine them into one from our panel or our attendees. Thank you again for asking questions, and please keep them coming. Andrew, this is really about the bare metal stent group. So the first comment is we're first and second generation bare metal stents. We know that there's a lot of evolution in bare metal stents, including the variant stent, biomimetic, and then now also the second question is with Supera. Is Supera pulled out or combined? You kind of talked about this already, and I think we know the answer. But should we have looked at nitinol woven stents a little bit separately? And if you have a chance to throw in the third part of this, was any comment on aneurysmal degeneration that came out of that data, which I don't think that was included in that analysis. So bare metal stents really is the focus of the question here.
Yeah, I mean, thanks, Eric. It's a diverse cohort of bare metal stents, including Supera, and I think there was an attempt at subgroup analysis to see if we could look at that cohort indifferent that is standard nitinol. I consider the nitinol stents more second generation than first generation nitinol stents, but as you know, a number of the biomimetic stents and so on weren't included in this cohort. I think we need to acknowledge that, and we don't really have the answer for error, and I think it's useful to know that head to head. I think one of the things I quickly comment is that we'll see from the other patients that we are starting to get more information the primary drug-eluting stent versus DCB and spot stent with nitinol. So I think that's something we're going to do, because that's often in my mind an issue in our algorithm. And finally, yes, as you know, we've looked at this very carefully, Eluvia and aneurysmal degeneration or other drug-eluting stents, and no, this wasn't something that we could report in any kind of incident.
Well, thank you, Andrew, for those insightful comments. I'm going to turn it over now. We're going to hear from Dr. Eric Secemsky, who's going to be presenting us on the treatment of in-stent restenosis with the Ranger balloon, 12-month data from the Elegance Registry.
Good evening, everyone. My name is Eric Secemsky. I'm the Director of Vascular Intervention at the Beth Israel Deaconess Medical Center, and I'll be discussing tonight the treatment of in-stent restenosis with the Ranger balloon, 12-month data from the Elegance Registry. I do want to note I am a consultant for Boston Scientific, and I also am on the steering committee of the Elegance Registry. So just an overview at the top of the slide on Elegance. This is really a novel approach to post-marketing data by Boston Scientific. So really give them credit for doing something a little bit different. This post-market registry is a multi-center global registry. And really the goal is to look at any vascular bed treatment with a drug elution device. So you can treat lower extremity, you can treat outside of the lower extremity as long as you used a Boston Scientific drug-coated device. These devices included the Ranger drug-coated balloon. In the US, we have these available for above the knee. Outside the US, we have these available for below the knee, as well as the Eluvia drug-eluting stent. This registry has a diverse enrollment, and really the objective was to have at least 40% women and 40% underrepresented minorities. So you are actually frozen out of the registry if you're not meeting this criteria until you catch up. And then each site is really charged with evaluating their patients as per standard of care at their local institution and follow-up. And there is some outcome cohorts here that will specifically look at data for patients with prescribed follow-up periods. And you can see here for data collection, the goal is to get that pre-procedure and index, and then we're following patients currently all the way up through 2 years. Currently, we're going to be showing you data up through 1 year. So again, really timely, novel registry. We've published some data from this, and I think you're going to see even more exciting data as this continues to mature. And I think this is one of the most unique data cuts to come out of Elegance to date. So again, let's go back now to in-stent restenosis. So in-stent restenosis here, we're really focused on those patients who've had prior peripheral artery, really lower extremity procedures and we're looking at those procedures that have now restenosed and been treated only with a drug-coated balloon. So some people will do repeat implants and whatnot. The goal here was to see how drug-coated balloon, which is my real protocol, performs in the treatment of recurrent end-stage restenosis for peripheral vascular disease with outcomes through 12 months. So hopefully everybody knows the Ranger DCB. I always love this Ranger DCB for several reasons. First off, Sterling was our balloon of choice in the cath lab. So we use Sterling balloons primarily as our 018 platform. And I always find that that's a really deliverable, nice balloon to start with. For the SFA and FEPOP in particular in the US, the 018 platform was a new platform wire at the time. Now there's other treatment DCBs that are available on 018, but 018 is really a platform that a lot of us have moved to using, particularly using IVIS. And so this is a nice 018 DCB, delivers really well. They have a 4 to 8 matrix in the US, so you can get anywhere from TP trunk up through the SFA and even common femoral. And then they also have really important sizes from 30 to 200. BTK, which is not available in the US, has a 2 to 4 millimeter balloon up to 150 millimeters in length. The transparent coating is a proprietary coating for Boston Scientific, which delivers paclitaxel at 2 micrograms per millimeter squared, and really fits nicely in the toolbox of the lower dose paclitaxel. Ranger DCB loading tool is really designed to protect that coating so you don't have a lot of systemic loss when the device itself is being delivered to the target lesion. So hopefully you're all familiar with this. Now we're looking at table 1 and really focusing on the first 150 patients treated for ISR with DCB from Elegance. You can see here that really nice split between male and female patients. So we don't see that very often. So that's another good sign that this registry is working as planned. You can see that diversity in enrollment. About 35% of people are identified as non-white, and you can see the breakdown in the table. A lot of prior smoking, 77%, over half of diabetes. So real-world registry here, 17% with renal insufficiency. Moving to the right table, you can see the lesion characteristics. 34% presented with a CTO in that target recalcified lesion. I want to highlight here that we forget how calcified restenotic disease can become, and you can see that up to 45% of patients had moderate or severe calcification involved in the interventional location. Primarily, ISR in this data set was in the superficial femoral artery, but you could also see some distribution in the popliteal, as well as the distal popliteal arteries, and also the treatment links overall. And then you can see below the knee treatment in about 4% of patients. So I really think this is an important part of this as well. You know, female patients tend to present with more advanced disease. So you can see here on the little bar table that popped up, there's a female and male split, and you can see the Rutherford 4 to 6, so really the CLTI population, is about 47% in the female patients and 29% in the male patients. Now, what was used in the prior interventions, you can see a nice distribution and pretty balanced between the two groups minus for PTA. So overall, we're looking at bare metal stents, DES, PTA, DCB, and atherectomy as a prior intervention prior to ISR. And you can see that for the most part, female patients had a little higher prevalence of PTA overall, but also following that also got higher prevalence of DES, so drug-eluting stent, as well as DCB, just numerically here. So again, there is some differences in how we're treating these patients. And I think although the PTA rates were high, there are also a lot of use of drug in female patients. And I think we all know that these patients tend to have smaller vessels, maybe a little higher risk for restenosis, more advanced disease, and maybe that's the reason really to focus on more advanced drug-coated therapies, either in conjunction with other therapies or even in conjunction with each other. Here is the cumulative incidence curves of CD-TLR through 1 year. So we're looking now at freedom from having a clinically driven target lesion revascularization of 84% among the total group. So again, these are patients who are coming with a high-risk lesion at a reintervention and now are making it to 1 year at a very high rate, I would say, for in-stent restenosis, 84.2%. And when you break that down by sex, you can see that there's no significant difference. So again, really nice and important to see this because, as mentioned, female patients tend to have smaller vessels. We know maybe a little higher risk for an adverse event. And you can see here in red, 84.7%, and blue, male 83.7%. So really a numerically similar rate of CD-TLR through 1 year. When you look at other outcomes, which are really relevant in this population, of those that had Rutherford categories available in 12 months, you can see that 68.6, and without TLR, I'm sorry. So these patients did not undergo another intervention and were available at 1 year. 68.6% of them had an improvement of one or more classifications of the Rutherford category. Only 1.3% of patients had an above ankle amputation, even though we saw a pretty high risk of CLTI, particularly in the female patients. And procedural complications requiring some sort of intervention, which just around 10%. So in summary, I think, we don't have a lot of data to guide us in in-stent restenosis. We know this is complex. My strategy is always trying to avoid another layer of stent if you're treating a stented area. And so really this data is one of the first and largest real-world evidence to support the Ranger DCB as an effective tool for in-stent restenosis. 84% CD-TLR 12 months, no difference between men and women, and really low risk of amputation. This is really an important adjunct to what we know about Ranger from the Ranger 2 study, that it performs well in both high risk and low risk populations. And I do want to highlight again, with the real mantra of the Elegance study is, let's get in patients who are excluded from trials, female patients, minority patients. And we saw in our stratified analyses that there really was no difference in outcomes between female and male patients, giving us confidence that this is the right therapy for all of our all comers coming in for a repeat intervention for femoropopliteal artery disease in particular. So thank you very much for the opportunity. I'm looking forward to a discussion, and thank you all for tuning in on your evening nights to have a webinar with us at Viva. Appreciate it.
Well, thanks. We'll go back to discussion now. I want to first ask Dr. O'Banian. She's always been a champion of both claudicants and CLTI. You've also been a champion of community outreach. First, what are your thoughts about Elegance as a trial design and what it's brought to what we know in science? And then how do you then look at this in-stent restenosis data in terms of how you incorporate it in your practice now as compared to maybe what you did 5 or 10 years ago for a patient with in-stent restenosis?
Yeah, I mean, Eric, this is a great presentation. And I think, it's always great to see these trials have a more inclusive patient cohort because we know that the data is out there that females are a very different population than males. We know that underserved socioeconomically diverse patient population is also very different. And I've heard people on the panel make a lot of comments about, for example, Dr. Holden was talking about how his patients always follow up and they're really compliant about taking their medication. If you live in Fresno, they don't. And so how does that affect, what tools you're going to use? Does it affect whether you actually leave metal behind, or are you a little more conservative because you're not going to have the same surveillance patterns? And so, how do you think, Eric, to your point, like, how do we interpret this data in how we treat females? Because this is a huge cohort. You've got over 40% females in here, which is a huge drastic difference from a lot of the randomized controlled trials and industry sponsored trials that we see. And so if you put this together with the last presentation, do we just use drug-coated balloons in females? Do we put stents in? And how do we, I'm still trying to figure it out, but I know that when I have a small little female and I have to treat her endo, I'm going to be much less reluctant in a claudicant. And then if they have CLTI, I'm really reluctant to leave anything behind. Obviously, with this data, we know that, if you do get in-stent stenosis, DCB really is the way to go. And I think that's how a lot of us treat now. But what are your thoughts on that?
As always, those are great insights, Leanne. And I think that's what's been fun with this data set, is to actually be able to support some of our gut instincts in terms of revascularizing female patients in particular. So just like you said, the interesting things that have come out of Elegance is the female patients who are enrolled. And again, it's an all-comer registry, but you have to get a drug-coated device made by Boston Scientific. So there is a little bit of enrollment selection bias, but if you're in that, and most of us are enrolling anybody who comes in the door in that registry, female patients tend to present with more advanced disease. And so we've seen that kind of routinely. Female patients tend to have smaller lesion diameters and long lesion lengths. So they, just like you said, they come in with complex disease, and there is a difference compared to male counterparts. I think that the treatment strategy has to keep that in mind. Smaller stents do know that from iliac intervention, and so I favor a non-scaffolding approach when I have smaller or longer lesions, and I think that's been a great insight here. And then when lesions have been stented, I think these data have supported really equivocal outcomes to using a DCB than probably what we would see with another layer of stent. I think the one thing that is really interesting also coming from these data is we've had a lot of prior studies that have demonstrated that female patients have worse overall outcomes after endovascular or surgical treatment. And at least in the endovascular part of this, the outcomes have been quite equivalent. So even after being more complex and more advanced disease to start, I think everything you've done, Leanne, and others in this space to try to improve, really the treatment of minority and female patients has started to pay off, at least per this registry, and we've seen pretty equivocal outcomes. So a lot of great data to come there.
Yeah, I mean, I think it's so important to remember that we have so many different tools in terms of vessel prep and IVUS to look at the lesion and make sure that you're, not leaving disease behind. And when you are choosing just to use drug and not a stent, that you're actually prepping the vessel well and that you're getting good luminal gain. And I think with all these tools, we can give women or females good outcomes with endovascular treatment. I think we just have to be mindful about it. But it's nice to know that using drug, we can have good outcomes and we can have good long-term outcomes.
Eric, may I ask you a quick question? It was amazing to see such good or similar patency rates, despite the fact that women were sicker when they came in. I think that was surprising. You showed the complication rate around 10%. Was that different by sex? Because it was just a single number. And then 77% smokers, like, wow. I think what are we going to do about that problem? But maybe just the were the procedural complications similar between the groups?
Yeah, great questions, Marc. I think two things have come out, and we did some of this work also for the FDA recently using a different data set. And although the longer term outcomes like amputation, reintervention tend to be similar, still procedural complications tend to be higher. And probably most of us observe this, like access site complications. I feel like I struggle more with my female patients than bigger male patients, closure device if you use them. So that definitely is a real concern, and it has to be managed and watched closely. And I gotta tell you, I mean, pretty much I only really do clinic. My only clinic's really PAD at this point. I don't really do any other clinic except PAD. And every time I see a female patient, I always tell my fellow, I'm like, don't ask them, if they smoke. Just ask them for how long and when they quit or did they quit. Because in particular for females, I mean, it's like in my practice, it's like 80% or more. So it's always shocking to see that number. Men, more diabetes, more renal disease, and other contributors. But females, it's like, pretty much they smoked and it damned them. And so, and some of them, years ago. But so it's always a sobering statistic, and hopefully that's the decades in the past and not the decades in the future that are still smoking. But we still see a lot of it, unfortunately.
Can I just ask a couple of quick questions, or comment and then a quick question? I think the problem with FO in females and smaller arcs is a real issue. We've tended to move away from allowing and oversight of standing stents, not subjecting the vessel to that ongoing outward force and driver for stenosis. But we've got vessels under 5 millimeters, then we limit our option drug-eluting stents, I should say. The other point, Eric, what about debulking? We often talk about the debulking stenosis, maybe drug-coated balloon, but it's very hard to beat this data here just with DCB only. Are there any cases where you think you add that?
Yeah, great question. Just to repeat the two questions. The first one is self-expanding stents and outward pressure, in particular smaller lesions like a 5 millimeter vessel. And then the second is the need for vessel prep, and is it really changing delivery of drug? And It's both are really great questions. I don't know I'm going to have brilliant answers to, but it's funny. I comment, and you guys hear me say this too often, from a coronary world, and we only have balloon-mounted stents, and so I had to learn about self-expanding stents, and I think there are some real concerns about outward expanding, self-expanding stents. And I hate to bring up Saval, but we saw below the knee that was not a successful strategy, and there could have been other reasons why that stent didn't win in that trial. But I think it's a real thought about whether that is the right strategy. Again, I think Leanne brought up nicely that this might be just that population where any stent could have some harm, and really sticking with a DCB first approach might be the right strategy. In terms of vessel prep, verdict's still out on this. I've been very aggressive about vessel prep for ISR. We do that primarily to debulk, some of that neointimal hyperplasia, neoatherosclerosis, get a good lumen, so you're left with a good lumen size when you DCB. In native disease, we've seen a lot of early data and translational data, but not the clinical data to support what we think vessel prep does for drug uptake and delivery. And so, I think it's hard to design the study. I've tried to think about the right way to do this many times. I still think vessel prep is important in specific situations, but it was not a primary strategy in Elegance Registry. I'll tell you that, differing from other data sets. And again, there's some just nuances with the data set and where that was run in the US, but we just didn't see a lot of atherectomy use and more IVL, but still limited in that data set.
Well, thanks, Eric. We're going to now hear from Dr. Leanna Banion is going to do our final presentation tonight. It's the 24-month data from the sports trial.
Hi, everyone, and thanks for joining in. I'm Dr. Leanna Banion from UCSF Fresno, and today I'll be presenting the 24-month data from the sports trial, focusing on endovascular strategies for complex femoropopliteal lesions. As you know, most of the prospective randomized IDE trials focus on shorter, less complex lesions like TASC A and TASC B. For the more complex TASC C and D lesions, we've largely had to rely on retrospective series or registry data, which often lacks standardized follow-up or a control arm. This makes direct comparisons and definitive strategy decisions very difficult. Treatment options range from simple balloon angioplasty to drug-coated balloons, bare nitinol stents, and drug-eluting stents, covered stents, and of course, open bypass surgery. But until now, we've lacked high-quality randomized trial data to truly guide us on which strategy should be first line in endovascular treatment of these long, complex lesions. The sports trial was designed to address exactly that. It's a prospective, randomized, 3-arm, multi-centered trial comparing paclitaxel-coated balloon, paclitaxel-eluting stent, and bare nitinol stent in patients with long TASC C and D lesions of the SFA. The primary endpoint was angiographic diameter stenosis at 12 months. The hypothesis was that paclitaxel-eluting stent would be superior to bare nitinol stent, and paclitaxel-coated balloon would be non-inferior to bare nitinol stent. Inclusion required patients with Rutherford 2 to 4 symptoms, the SFA or P1 lesions at least 13 centimeters long with significant stenoses greater than 70%. Exclusions were in-stent restenosis lesions, acute thrombosis, vessel diameter less than 4 or greater than 6 millimeters, tibial disease requiring treatment, severe circumferential calcification, or poor vessel runoff. Although I will note that 50 to 70% of the lesions were PAX 3 and 4 lesions. So there were a good degree of heavily calcified disease within the study. 224 patients were enrolled across 3 arms. The paclitaxel-coated balloon was 74, paclitaxel-eluting stent was 74, and bare nitinol stent was 76. Follow-up included ABI, duplex, and angiography with excellent clinical follow-up rates at both 12 and 24 months. When looking at the patient baseline characteristics, most patients were Rutherford class 2 to 4 with a high prevalence of traditional PAD risk factors such as diabetes, smoking, and hypertension. And the groups were very well balanced. There were no significant differences between these arms, so we can be confident that outcome differences are due to the treatment itself and not differences in the patient population. It's also worth noting that compared to many IDE trials, patients in sports had more advanced disease profile, which most IDE trials exclude. Now, when we look at lesion characteristics, This really highlights why sports is such an important study. The average lesion lengths were well over 20 centimeters, and I think that really highlights the complexity of the lesions. And about half were chronic total occlusions. Calcification was also common, with a large proportion showing moderate to severe disease. And this is in stark contrast to many prior randomized trials, which typically capped lesions lengths around 10 to 15 centimeters and often excluded CTOs. By enrolling true task C and D lesions, sports gives us one of the first high-quality randomized data sets in these complex lesions. Another thing that I want you to note that's really important that I have highlighted in the blue box is that in the paclitaxel-coated balloon arm, 58% of patients required bailout stenting. And I think that's really important when we look at the data, because in my mind at least, and I think in a lot of our minds, when we drug-coated balloon and then we bail out stent, we almost kind of think that we've created a drug-eluting stent. But what you're going to see here is that we actually have not. At 12 months, paclitaxel-eluting stent outperformed bare nitinol stent in terms of angiographic diameter stenosis, late lumen loss, and minimal luminal diameter. And paclitaxel-coated balloon demonstrated non-inferiority compared to bare nitinol stent, meeting both hypotheses of the trial. I will also note that one unique characteristic of the sports trial was that the trial mandated angiographic follow-up at 12 months. And so all of these patients had imaging at 12 months via angiography. Looking at the primary patency at 1 year, Kaplan-Meier analysis showed a clear advantage for paclitaxel-eluting stent over both paclitaxel-coated balloon and bare nitinol stenting. Similarly, freedom from clinically driven TLR favored paclitaxel-eluting stent compared with the other two strategies at 12 months. By 24 months, paclitaxel-eluting stents continued to demonstrate the best results. Interestingly, paclitaxel-coated balloon also pulled ahead of bare nitinol stent at this time point, showing statistically better durability. Freedom from clinically driven TLR remained highest in the paclitaxel-eluting stent group at 24 months, though the gap between the paclitaxel-eluting stent and the paclitaxel-coated balloon narrowed. When looking at major adverse events, including clinically driven TLR, amputation, and death, paclitaxel-eluting stent again showed the best outcomes, highlighting the clinical relevance of improved patency. All treatment groups showed improvements in ABI and Rutherford category compared to baseline, underscoring that endovascular therapy in general is effective for symptom relief. That said, paclitaxel-eluting stent patients tended to have more durable improvements. These results, again, align with other major femoropopliteal trials, but sports stands out as one of the few randomized data sets focused specifically on long, complex TASC C and D lesions with mandatory 12-month angiographic follow-up. To summarize, paclitaxel-eluting stents achieved the best angiographic and clinical outcomes with superior patency and lower TLR rates. Paclitaxel-coated balloon was non-inferior to bare nitinol stenting at 12 months and outperformed bare nitinol stenting at 24 months. And overall, for TASC C and D lesions, paclitaxel-eluting stents should be strongly considered as the primary endovascular strategy. Thank you, and I'm happy to take any questions.
So that was fantastic data, Leigh. We'll go ahead and reopen it back up for discussion with our panel, and maybe I can go to either Dr. Metzger or Dr. Patel first for a question or comment.
Well, Sean.
Sure, Sean.
First of all, Leanne, here's the presentation, and I think this is very valuable when you have these long, complex lesions in a randomized trial, and you have angiographic follow-up. I think, honestly, for Chris, that's gives more insight than driven TLR, which is really kind of has too many variables for me. This gives you real patient level data, and it is outstanding study. Was there any difference, a question here, in terms of once you randomize what your pre-treatment strategy was for each of the three arms that you were randomized to? Was it all balloon prep followed by the various of the three technologies? And what were the bailout criteria for stenting? This kind of led to Andrew's initial point. The longer the lesions tend to have more than 50% bailout stenting. So what was the vessel prep that was mandated by the trial, and what were the bailout stent criteria?
Yeah, so I might lean to Eric to correct me if I'm wrong, but I believe that there were any modality of vessel prep was allowed in the trial, whether it be plain old balloon angioplasty or atherectomy or such. And then, the bailout stenting was really physician dependent, and that's when they crossed over in the arm. And so it was left up to the physician whether or not you thought the lesion, was not satisfactory after drug-coated balloon. And I think it's interesting because when you think about the long lesions, in my mind, there's two different plaque morphologies that we have to take into account that I didn't specifically talk about. And that's like the soft plaque and the patients that you cross subintimal. And then there's the heavily calcified plaque or the plaque that you're able to cross true lumen. And that's really hard to, differentiate in a trial like this. But for me, that makes a big difference whether I'm subintimal or whether I'm true lumen as to whether or not I'm going to leave something behind. So, for my take home from this is that irrespective of vessel prep, and when you look at IVUS, if you cross subintimal in a long lesion, that drug-eluting stent's probably the way to go. If I'm true lumen, I think I'm going to have a little more pause as to whether or not I'm going to leave something behind if I get good luminal gain, right off the bat with my vessel prep. That's just my own personal, thoughts, take home from this.
So Parag,
Hey,
your
Leanne.
thoughts?
Yeah, Leanne, I have a couple questions. First of all, thank you for this presentation. I think a prospective randomized trial looking at these really long, complex lesions with a high percentage of CTOs is exactly the type of data that's more like the real-world patients we tend to treat and manage. So this is really unique in many ways, and I think you did a nice job of highlighting that. And I think also some of your findings seem to follow along with the meta-analysis data that Andrew showed earlier in this webinar, the long data set and the superiority of drug-eluting stents compared to the other technologies. I think in most people's algorithm, and I think you just touched on this in your last answer, initial vessel prep with a balloon or whatever approach you take, then deeming do you have adequate patency before you move on to your drug-eluting technology is the route to go. But in this particular trial, you randomized to paclitaxel-coated balloon. You did your vessel prep, and regardless of that, you then treated with the balloon because that's what they randomized to. And then if you still didn't have adequate treatment, which wouldn't typically be our algorithm, you may have had a bailout, which in this case was 58% to a stent. But you still had superiority in that cohort compared to bare metal stents alone. So is this to suggest that bare metal stent or paclitaxel-coated balloon with a stent is certainly better or not inferior to bare metal stent, but it's not better than drug-eluting stents? I mean, how did this change your algorithm, or does it, or does this really just further underscore the need for maybe a vessel prep and spot stent approach versus a primary stent for long lesions, which is what Andrew's data suggested is the best approach if you don't have a good vessel lumen after prep?
I mean, I think these are amazing points. And I think when this isn't a one size fits all. And I think you have to take the patient that you're treating. I think you have to take the plaque morphology. I think you have to look at what type of disease you're treating. Are you treating claudication or are you treating CLTI? Do you have outflow disease? And then, beforehand, I'm guilty of saying automatically, I cross the lesion and I know what I'm going to do. Like I have it in my mind already, I'm going to stent, or I have it on my mind that I don't want to leave anything behind. And I think this data kind of makes me want to change my algorithm to think, okay, how did I cross? What did I prep with? Was I able to get good prep? And what does it look like? And I mean, if it doesn't look perfect, then maybe a primary treatment with drug-eluting stent is the way to go. And so, for me, I still don't like leaving anything behind. I just, maybe one day my mind will shift. But I think this data is really convincing that we need to really evaluate our vessel prep and, be mindful that there are good options out there if we don't have a perfect angiographic result after prepping.
So Eric,
can I just add? Sorry, Sean. I just add that it was really interesting, and congratulations, Leanne, on a lovely presentation. But one of your key takes out of this was the same mine when I saw this data at Charing Cross, and really, it's the best data we've had comparing head to head the strategy of primary DCB with provisional stent versus primary drug-eluting stent. We had real DES, which was DX versus bare metal stent and BCB. And you remember that the patency difference in a much smaller trial with shorter lesions weren't different at 1 year, but there was a benefit for primary DES 2 years. But here, we've seen a much more powerful difference in latency between those two strategies. So I think Lan's right to say we all would much rather finish our procedure with an artery without metal in it. But I think, as I said before, I think this does change thresholds in decision making. It doesn't prejudge, but it potentially changes how we interpret after our vessel prep whether we're going to go for a scaffold or not. So I think this is really important, 1 and 2 year data of those two arms of the trial.
So, Eric, what questions we have out there from our attendees that have come in from online?
All right, great. So we have one heartbreaking question that came from an anonymous attendee. And I was doing a little Googling because I didn't have the answer here. And I'm not sure, Leanne, if this came across your plate, but it said, why do you think Eluvia did so much better in sports versus 3-year data from Eminent? And just to remind everyone, Eminent was a trial that randomized the Eluvia drug-eluting stent to a combination of bare metal stents. So kind of our first conversation, a combination of both any first, second generation bare metal and nitinol woven Super stents. I can give you what I found online, but I don't know if anybody has an answer. Any concerns about how Eluvia data extends past 1 year compared to bare metal stent in particular for this question? Okay. Silent. So I haven't seen much of these data presented. I found an FDA filing though, and there was a drop off in the patency rates out to 3 years. Now, at the same time, there was about 100 plus patients who were no longer available to follow up. And we've really learned a lot about loss to follow up and how that impacts our longer term outcomes. So although there was a loss in patency that made it more equivocal between bare metal and drug-eluting stents, I think there should be some caution as we know this can be challenging in terms of compliance with ultrasound follow-up and other outcomes. So that was the best answer I could come across. I haven't seen this in my own practice where patency rates for Eluvia tend to drop off significantly. Andrew, you kind of made a comment about this in your talk to start. So I don't know if anybody has any more comments here, but just trying to be balanced with our approach with the longer term data here.
I will say, Eric, I think it also depends on your practice pattern and how your patients follow up as to what your data looks like. If you have a patient that diligently follows up and gets ultrasound surveillance every 3 months and you pick up on significant instant stenosis versus having a medically compliant patient versus not, I think all those play a factor. So it's really hard to say, what causes what when there's so many things at play that come into long-term patency.
Anybody else, any concerns about drop off with Eluvia? We've had these available now for about 5 years. Doesn't seem like it, much concern there.
Yeah, I don't really see a big drop off happen year to year. Whereas, my experience with other platforms are that, there does hit some plateau and it tends to sort of stabilize out. But the Eluvias tend to really perform very well. I have much less angst in putting in that stent now than I ever had before with any other stent platform. I got to admit that, when the data set sort of conforms my observational bias, it's nice, but it's always nice to have the data to support what you think you might be seeing in your own patients. Any last closing questions or comments from our panel?
I think this was compelling data from Europe and a very nice discussion. This was very informative, and I'd like to thank Boston Scientific for sponsoring this. It's a great session.
Yeah, and so I want to echo that. I want to thank all our panelists and our speakers for joining us tonight. I hope everybody found this multidisciplinary discussion helpful to their practice. From Viva, we know that many people don't get to Europe. For the investigators who led some of these trials in Europe, we would have loved to have them join, but it's 2 and 3 o'clock in the morning for some of them. So we did not feel that was a really a great ask. We appreciate Dr. Holden, who's almost a half a day ahead of us, for joining us this morning. And so I want to thank everybody for coming. I really want to thank Boston for sponsoring, and I hope to see everybody at our meeting come November 1st in Vegas. So with that, I want to thank everybody, and we'll wish everybody a great night.